Hi, I'm Courtney.
Hi, I'm Zeal.
I'm Allie.
I'm Megan. This semester we were all in the same clinical group, and we were put on 7 North at Gwinnett Medical Center, which is normally an orthopedic unit for post-op patients from total joint replacements. But since we are kind of an overflow unit for the hospital, we get a lot of different post-op patients who are in a lot of pain, and our nurse to patient ratio is about 5 to 1.
So as students giving out these pain medications, we thought our PICA question could be pertaining to that topic of pain as like an issue with post-op patients that are coming to the floor. Because their pain medication is scheduled every 3 to 4 hours, we thought that was a big issue with the patients that we've been seeing on the floor this semester.
They call out pretty frequently, about every hour or two, for some sort of pain medication. So as the nurse, you're trying to figure out what pain medication's ordered for them. There's usually 3 or 4 PRN medications, so which one can they have? Do they know about this medication? Are they familiar with it? Are they willing to take this medication? There is a lack of knowledge in a lot of our patients on like Dilaudid and morphine, and they associate those with like being addicted and having really bad side effects. So it's been a big deal this semester for us having one patient to schedule their PRN medications. So as a nurse having 5 patients, I can only imagine having to do that for all of your patients.
And even though we do pain medications, I feel like we've been doing a lot of non-medication interventions that help with pain. But I feel like with post-op patients, pain and medicating them on time is a big factor to improve their pain and their ability to perform their activities with physical therapy while they're in the hospital being taken care of post-op.
Especially because like PT comes in within 2 or 3 hours of their surgery to get them ambulated, to get them moving, to help them brush their teeth, to put their clothes on. And there's only so much positioning them can do.
And a lot of times patients don't realize that medicating before the pain actually starts is better for PT movement, actually putting on their clothes, walking down the hallway to be able to have them be discharged sooner. A lot of people think, oh, I'll just take the pain medication when I really, really hurt versus, going ahead and taking it and needing it.
So then that puts the nurse in a predicament of having to answer the call right then and help them with their pain like right then when they're having to take care of 5 different patients and do all these different things for all these different patients. Throughout our semester on the post-op unit, we realized that the nurse-patient ratio is really large, and patients' pain levels are not thoroughly taken care of. The nurses on our floor have on average 5 patients per nurse, and each patient normally has about 3 PRN pain medications ordered. Aside from having multiple comorbidities to manage, our nurses spend most of their day answering calls from patients reporting pain, going in and assessing their pain, and trying to figure out which pain medication they can have at that time. They then have to chart the assessment and intervention and then move on to the next patient calling out for pain medication. Our nurses report spending about half of their day doing this, leaving the other portion of their day to tend to the patients and their other needs, such as monitoring them postoperatively for infection, preventing deep vein thrombosis, and monitoring their other comorbidities. They often are run ragged by the end of the shift and aren't able to holistically care for their patients throughout the day. After spending the semester working alongside these nurses, we saw this large patient load and long list of PRN medications to keep up with as a problem and wanted to look further into it. We wanted to take a further look into patient satisfaction with intermittent nurse-administered pain medication in comparison to patient-controlled analgesia. Here, the patient could control their own pain level and satisfaction by pressing the button themselves on their own time after education, and the nurses would have more time to holistically take care of that patient and could handle the patient load being thrown at them. We understand that with this, like all things, there will be risk and benefits of placing postoperative patients on patient-controlled analgesia, and we would like to see how clinically significant this change could be.
Our population was postoperative patients. Our intervention was patient-controlled analgesia. Our comparison was intermittent nurse-administered medications. Our outcome was decreased reported level of pain, and our time was during the hospitalization. So our PICO question was, when trying to think of a focus for the study, we focused on, do postoperative patients have decreased reported levels of pain with patient-controlled analgesia compared to intermittent nurse-administered medications during hospitalization?
The keywords we used while searching were PCA pump, pain relief, postoperative patients, patient-controlled analgesia, nurse-administered pain medication, and intermittent pain medication. Throughout our search, we retrieved 22 articles, we eliminated 16, and all of our articles were retrieved from CINAHL and PubMed. The limitations we used as we searched were nurses as authors, English, between the years of 2010 to 2015, and articles that were not peer-reviewed. We ended up using 8 articles and found relevance throughout these, as findings of the articles selected showed significance in using patient-controlled analgesia when compared to intermittent nurse-administered pain medication. When used with education, we realized that education and understanding play a large role in decreasing anxiety and controlling their pain level.
The next part I'm going to cover is the findings table and a brief synopsis of each article. Article 1 addresses the use of PCA pumps to help with pain level to help improve the activity, sleep, appetite, mood, and ability to perform PT for post-op patients. Article 2 talks about the cost of PCA pumps, and even though they're expensive, can provide a significant amount of pain relief with post-op patients. Article 3 recognizes the lack of communication and education with post-op patients and how it impacts their anxiety and pain level. Article 4 talks about PCA providing effective pain management with risk associated with the use and how benefits must outweigh the risk while using a PCA pump. Article 5 informs the readers about PCA, leading to a high level of comfort and satisfaction due to the ability to provide medications on their own time. Article 6 shows pain level to be lower with post-op patients using a PCA pump compared to PRN medications. Article 7 talks about the patient satisfaction and how the rate is higher when receiving PCA therapy. Article 8 talks about PCA reducing the amount of time required for the nurses with the patient's care and allowing more focused assessment and hands-on care. The main article we're critically appraising is an article by Teresa Lambert, who's a BSN nurse and the Director of Surgical Services Orthopedic Inpatient Unit in Florida. The purpose of the study is to compare 2 methods of pain relief. One, nurse-administered pain medication, and the other one would be a PCA in post-op patients with total knee arthroplasty. The hypothesis was the patient-controlled analgesia used with education and knowledge would deliver better pain control for the patient and a higher level of patient satisfaction and a decreased level of fear and anxiety with the patients. The sample size was obtained by the 4 surgeons of 30 patients in each group that were going to be receiving the total knee arthroplasty. The patients were based off the surgeon and were not randomly assigned to groups. The intervention for the study was a PCA analgesia with the experimental group. The intervention was consistently provided and delivered, and the groups were treated equally, as the nurses weren't aware of the interventions. The study had an inclusion and exclusion criteria, which included the following. The patients had to be 18 years or older, be able to sign their own consent, be able to fill out their own questionnaire, be able to swallow medications, have no history of drug use, not be pregnant, not be needing hemodialysis, and could not have a pathological fracture. Also, no allergies to the drugs that will be given during the study. The study had a dropout rate of 0%, which means the participant that started the study made it till the end. The method that was used to record the result was a reliable numeric pain scale that ranged from 0 to 10, which is part of the questionnaire that was given to the patients post-op at 48 hours after their surgery. The results showed PCA patients having significantly better pain scores and reported less pain interference with activities that were performed during the day, along with better mood, sleep, ability to perform physical therapy, and a better appetite. Since the evidence was taken from a quantitative comparison study, it shows a strong level of evidence. The study was very well conducted, with limited amount of bias, although the sample of participants could have been larger in number. The findings were controlled. The findings were credible and clinically significant, and we do believe that the study shows implementing PCAs will be highly beneficial in patient satisfaction and better outcomes in clinical setting.